Well, welcome. Today we're going to talk about polypharmacy and deprescribing in geriatrics. My name is John Swegel and I am a professor over at the University of Iowa College of Pharmacy. And this is part of a series. You will get other talks specifically looking at deprescribing in the geriatric population, but this is sort of a general overview, and the crux to this is probably going to be more on the polypharmacy aspect of things. But I will give some tools on deprescribing and how you approach that. Conflicts of interest. I do not have any conflicts of interest as listed there. I have no financial relationships to any companies, and I will not talk about any pharmaceuticals, medical procedures, or devices that are investigational or unapproved for use by the FDA. These are the learning objectives, and you can kind of read through these on your own. I do want to highlight just a couple of things. We know polypharmacy exists, and recognizing that I think is an important aspect, and then the effects that it has on those patients. And then we'll talk about some tools today. I'll look at giving you some approaches to help with facilitating this deprescribing idea, and also look at other ways or different approaches that we can reduce unnecessary medications in the elderly. So what is meant by this medication consumption? How do people use medications? How is it defined? There are two main ways you could look at that, one of which is based on the population alone. 36% of the community-dwelling older patients are taking 5 or more medications. And then 80% of those 65 and older have 2 or more chronic conditions. If you just look at consumption, those that are 65 years of age, they consume more than 30% of the medications that are out there for prescriptions and over half of the over-the-counter medications. Now this slide is nothing new. It should not be anything that shocks anyone. It's the older you get, the more chronic conditions you have. Invariably, you're going to be using more medications and more therapies. If you look at a case, I have a case here of one of our nursing home patients, and this is an 89-year-old female that has dementia, she has COPD, atrial fibrillation, CKD, osteoporosis, heart failure, and osteoarthritis. And I want to just highlight an example of what people would perceive to be polypharmacy. This is a list of her medications. So just look at that. I don't expect you to look at the details of the medications that this patient has, but nonetheless, she has a lot. And if you think about that, if you go back and say, well, is she consuming too many medications? The short answer is, I don't know. I don't know this case well enough to say, but I do know that she's on a lot of medications. If you go back to the case, she doesn't even have diabetes. Imagine if this patient had diabetes, you could throw 3 or 4 or 5 more medications on board. And so this is what we want to address today. Not that we're inappropriately treating this patient, but I think it's important for us to understand that the medications can add up fairly quickly, and then you get cases that look like this from a medication standpoint. So what is polypharmacy? Just the general term, it typically means lots of medications, and it's not really been clearly defined. Numerically, a lot of people look at 5 or more medications as being deemed polypharmacy, but in all honesty, that's too simplistic. 5 medications, that you can be on 5 supplements over the counter. But the complexity of medications, the complexity of disease states that we have today, it doesn't make a number per se as a good definition of what is polypharmacy. You can look at it from a qualitative standpoint, and that really is what we're focusing on, and that's using multiple medications, but using them in an unnecessary manner. The downside to the term polypharmacy is that it implies that it's inappropriate. And this may or may not be the case, but a lot of people do associate polypharmacy with inappropriateness. And the intent of the medications, I believe, is to do good, but sometimes there's potential for more harm to be done than actual good.